So let's get into, diagnostic criteria. So how do we say for sure, okay, your symptoms are related to LPR because of, boom, 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 these things. So what are you looking for when you start to kind of move on to your physical exam, your scope exam?
So for any throat complaint, I always offer flexible nasal laryngoscopy. No matter what the throat symptoms, that's why you're here to see me and I need to do that physical exam. I think it's really important to understand, though, when I'm doing my scope, I'm not doing it to rule in reflux. I'm doing it to rule out other things, right? So I'm doing a physical exam because I don't want to assume that there's some reflux there and you had glottic insufficiency or a polyp or something contributing, right? So I'm doing it to rule out things. Now, classically, when we think about LPR findings, we think of certain things, right? So we definitely all think of that post-cricoid edema or erythema, the classic intra-arytenoid bar of mucosal hypertrophy. We think of kind of mucus at the level of the vocal folds, right? So the vocal folds themselves are producing mucus. And then we think of like the pseudosulcus. So the pseudosulcus is that kind of thickening where it looks like kind of chronic edema type of picture on the undersurface of the vocal folds. Lingual tonsil irritation, hypertrophy has been associated as well with LPR. The challenge with all of these are a lot of these findings are subjective, right? So is my intra-arytenoid bar, what you would call a bar? What is post-cricoid edema? Like, what if someone's just born with that size of post-cricoid mucosa? And that's definitely very challenging. Now, a lot of my colleagues, a hot topic in laryngology these days is kind of the artificial intelligence world, right? So can we upload these images onto a program that could then give us a diagnosis? Sure, that would be fantastic if that gets developed, but currently it's incredibly subjective what we see. And so what I always tell patients, because this is a little bit of a pet peeve of mine, is that, they'll say, well, I was scoped and they saw reflux. Well, no, you can't see reflux because it's happening in your esophagus. What they saw were signs that looked like your larynx was irritated. Okay. But again, that's not a direct definition of LPR, right? Because lots of things can irritate. So the reason we scope is to make sure we're not missing something. I've had cough patients where we found a tumor, right, causing their cough, or dysphagia and there's a hypopharyngeal tumor. Like, the reason we scope is to make sure we're not missing anything else. And then we kind of look for signs of really, really inflammation. But most of these patients, when we scope them, there's not really anything striking. It's all very kind of subtle changes. And again, how much of that is somebody's baseline? Well, we don't scope everyone all the time. So it's really challenging to use your scope to make an actual diagnosis. So coming back to your question about like what diagnostic testing or tools are available to us, we're somewhat limited right now. I do consider the gold standard for diagnosis of LPR, kind of the 24-hour pH impedance test. That's probably the best diagnostic tool we currently have. This is also incredibly limited because it is not necessarily an easy test. It's not offered in a lot of ENT practices. It's uncomfortable for patients. And so part of what I do when I see patients, again, a lot of them have already seen an ENT previously, but what we talk about is the test. We talk about it being kind of the gold standard for diagnosis. And then we say, well, if you're not ready, and I can understand that, right, for these symptoms, then we can talk about perhaps empirically treating you. But we have to be very clear that it's an empiric treatment, right? So I cannot say that you actually have LPR if we're empirically treating you. But again, a lot of these are quality of life symptoms. We've ruled out big bad things. We have the flexibility to kind of work through some of this.